Hello and welcome to CGTN's roundtable discussion on building consensus for global health. I'm Jiao Yang. And when it comes to any global health issue, the very foundation is collective action and collaboration. But in medicine, the same condition doesn't always lead to the same decision. And these different approaches, they're often rooted in deeper differences, say in social, cultural context, in medical philosophy, and the understanding of risk. So then, how do we achieve consensus? Well, today we're bringing together perspectives from China, Europe, and beyond to explore how divergences can, in fact, be turned into greater understanding that can foster collaboration and a more inclusive vision of global health. So, joining us today, we have Dr. Wang Qiusheng, Professor and Chief Physician at Peking University People's Hospital. We have Dr. Li Wen, Chief Physician, Professor at United Family Healthcare. And joining us online, Dr. Luigi Boni, Professor of Surgery at the University of Milan, and also Dr. Benjie Tang, Professor of Medicine at University of Dundee. Thank you all so much for being with us here today and for taking the time to speak to us. Now, let me start with an example that all of you will be very familiar with, and that is gallbladder diseases. Now, correct me if I'm wrong, but when it comes to the treatment of gallbladder diseases, there's the debate in the field of whether to preserve the gallbladder or to remove it altogether. So, Dr. Wang, how is it then that these different approaches to treatment has come about? What do you think drives this?
Oh, yes, this is very interesting questions. Gallbladder disease is very familiar in the public. It's very popular. The first, usually the patient during the cholecystitis with a small gallstone in the early stage, the patient asks for the physician. We could just use conservative therapy. We also call non-surgical therapy. As the several attacks or symptoms, with symptoms this kind of disease, the patient usually to ask for a surgeon. In surgical field, we have several approaches to select, such as open cholecystectomy, laparoscopic cholecystectomy, and in China, more and more patients and more surgeons are choosing gallbladder preserving surgery. It's quite different. So we have different criteria for this. Open surgery is very conventional, lasted for more than 1 century. Laparoscopic surgery has developed more than almost 4 decades. And gallbladder preserving surgery in China about almost more than 3 decades. So the patient much more involved in the decision because they got more and more information about the disease.
But that's something I'd like to come back to you about a little bit later. Professor Boni, you've worked in different countries. How then do you see the factors that shape different decision-making for treatment?
Well, yeah, I totally agree with what has been said so far, because it is very often the decision is actually nowadays is shared with the patient. First of all, because the patient comes to the clinic very much prepared. Now, they go online and they check all the information. They know more, actually, sometimes more than the doctor, actually, what happened when you remove the surgery. So it's very important to see what actually is their desire. Of course, if the patient have multiple attack of inflammation of the gallbladder or a biliary colic, well, the surgeon and the physician usually are more keen actually to propose a surgical approach. It's slightly different actually when you are dealing with the patient that have, they discover gallbladder stone by a routine check that they do it nowadays, at least in our latitude. And in that specific cases, you need to really share the decision with the patient. In theory, if you look at the scientific evidence, an asymptomatic gallstone is not an indication for surgery. There was a study actually was done in Italy, indeed, many years ago. They follow up patient for 20 years with gallbladder stone, and they found that actually if the stone were asymptomatic, there is no indication for surgery. Well, it's slightly different when you're dealing then with young patient with very small stone that actually can have more complication. Well, in that specific cases, you really need to approach the patient and actually see what his purpose is. There are patients actually, they don't want to live their life with probably the possibility that actually someday they will have a pancreatitis. This is a complication of gallbladder stone. Some other patients have significantly disease. Nowadays, we see patients, actually a very elderly patient, that actually may have comorbidity. So in that specific cases, maybe a more a more limited approach is important, because you see gallbladder removal surgery, even especially with the minimal invasive approach, is seen as an easy operation. There are no easy operation in surgery, so every operation can lead to complication, and gallbladder surgery can actually have a severe complication that actually can impair the patient life, although very little percentage, but there are still important complications. So it's definitely, and I totally agree, you share the decision with the patient.
So, Dr. Lee, do you think, we talked about gallbladder diseases as an example, but just in other medical cases as well, do you think perhaps different approaches and treatment also reflect maybe a deeper difference in, say, medical philosophy or perception of risk?
In ancient time, the Chinese people do not remove any part of the body, even the hair cannot be cut, and preserve anything. The people believe any part of the body belong to their parents. The parents give everything to the children. So the people like to save any organ, even some disease organ, just like cholecystitis and even the appendicitis, and try to preserve that. So the deep situation about the body preserving maybe make the difference between the Eastern people and the Western people. So this why the preserved surgery more popular and in China compared with surgery in the Western. With the deep philosophy consideration maybe related to that.
Well, Dr. Tang, do you think differences like this, do they often present as a hurdle in your medical practice? And do you think these are differences that are bridgeable?
Yes, I think these different decisions for the same medical conditions are not random. And so there's no, from my perspective, there's no such a thing as one size fits all. I think it's these individual cases, maybe patient's condition is different. And nowadays, as Professor Boney said, we move towards this kind of, how to say, it's patient preference and shared decisions. And also you need to discuss with the patient. And some patients may just do not want to have a organ to be removed, as Professor Lee said. And some patients want to just, get rid of the risk. And so, yeah, I think it's very important. That's why we have this program to address all these philosophies, these variations in medical practice.
Professor Boney, would you say medicine is moving towards personalized decision-making, or is this what the mission of medicine has always been about?
Very likely, I think that personalizing therapy in general is actually the key for this success. As Dr. Tang just said, one size doesn't fit all. And this is actually the nice things of medicine, and is also the most complicated things of medicine. This is extremely important, because even within the same cultural aspect, then if we start making and thinking about globally, I mean, we just saw that usually in some of the Chinese population, for instance, they don't want any type of removal of any organs. And if this is something that is absolutely acceptable, because it's part of the culture of the people. And even in Europe, for instance, we have different approach for several diseases. For instance, when we talk about oncological surgeries, most of my activities, what we do here in Italy not necessarily actually fits what they do, for instance, in in the north of Europe, where actually, for instance, for very elderly patients, they have a more conservative approach. On the contrary, our population, that is actually probably the oldest within Europe, we tend actually to give a chance, an opportunity for treating even surgically, even cancer. So this is actually very much important. And actually, if you allow me, just 1 minute, that actually fits very well in one of the key aspects that we are facing in the last few years. For instance, the use of artificial intelligence for decision making for our patient. When an algorithm, an artificial intelligence device that actually help us to choose which one is the best treatment for our patient, they have to take into consideration also cultural things, because what it fits for us, not necessarily, and we just heard it doesn't fit for China, for the east of Europe, or for the east of the world. So this is very important. So definitely is a decision sharing and is a cultural aspect that had to be taken into consideration. About personalizing the treatment, I always thought that this is actually the key of success.
Professor Wang, can we get your thoughts on that?
Okay, I quickly agree with Professor Bonnet, and the cultural background is very important to the decision making between the surgeons and also for the patient. So secondly, I would like to say we have a strict indication for gallbladder preserving surgery. So in the conventional surgical strategy, we have a wait and see for silent gallstone and for mild symptoms of this kind of disease patient. And now between the cholecystectomy, before the cholecystectomy, we have another alternative approaches for the selection for the patient provided by the surgeon. So in China, every year nowadays, we have about 1/10 of the patient choose the gallbladder preserving surgery, accounting about 1/10 of about 100,000 cases every year nowadays. So I would like to say the patient decision, the patient requirement is the seeking of the surgeons.
About the AI and technology point that Professor Boni brought up, Professor Tang, I'd like to bring you into this part of the discussion. So I know that you are leading a team to develop an AI-based self-training platform for laparoscopic surgery, for example. So AI and technology, clearly that is also penetrating the medical field and making changes to how you factor in decisions and stuff. But I wonder, does that in some sense help to unify decision making, because in a sense you're putting the thought process and you're putting risk assessment into the hands of tech?
Yes, I think AI is everywhere. So in medical practice, in both in surgery, in internal medicine, and we have started using AI to reshape whole decision, how we make decisions. But in my point of view, they are not replacing clinical judgment. So I think that is quite important. I think in three aspects, which is very, very important to apply AI in clinical medicine. So normally, this AI can really help us to make a better prediction. Yeah. So that is one thing, and also can help us to make a deeper personalization. Nowadays, we talk about a lot of shared decision making. And the third one, I would say, and this really can help the workflow of decision making. And in particular, we will involve the patient, because nowadays information is very accessible for the patient, as Professor Boni just mentioned. And patient, they normally do their homework. They get online and they use the AI, put all the information they have, and the AI can make a prediction and even come back a kind of possible solution for the condition. And the patient, they get very well prepared before they come to see the doctors. I think that's the three areas I think AI can have a big role to play, mainly just as I said already, improving prediction, expanding personalization, and changing the workflow of decision making itself. Yeah.
Yeah, absolutely. I mean, with AI and this access to information, I mean, patients are able to find out information that in the past they could only get from doctors as yourselves. So definitely changing the game here. Dr. Lee, how have you seen the development then of technology and how that's been influencing shared decision making with patients here in China?
I think the gap between the medicine and the general people's idea, it's very, very nearly and very, very small. So it's a challenge for the doctor, especially in the clinic. In the past, we know almost everything, but the patient do not know too much. But now everything changed. The gap between smaller and smaller so far. So we have to give the patient a new idea and even how to explain the patient. So this, I think, as a doctor, it's a new challenge. But it's a good situation. This new development put the medicine approach more and more and to the truth, I think.
Absolutely. I mean, challenge is exactly what drives progress, right? Professor Wang, so if there isn't just one single approach to any treatment decision making, how then do we build consensus moving forward?
Yes, sometimes just like you mentioned the AI. AI just helping us, help not only the surgeons, also the patient to comparing the different choices, which is better, which is not so good. So just several months ago, I tried to practice with AI to help us to make the surgical strategy for advanced gallbladder cancer patient. The patient just developed very fast with the jaundice. He says that the tumor from the gallbladder metastasis to the liver, lung, and widespread. So he lost the chance of resection. So we have to transform it to use combined therapies for this patient. So the AI, we comparing the several AI models and comparing between their consensus and the disputes. And then we decided ourselves and with the patient and their relatives.
Yeah, so clearly discussion and learning from each other is very important in any form of medical progress. Professor Bonnie, but do you think what you learn from a different region, a different health system, is that easily applicable to an entirely different health system in terms of different cultural backgrounds?
Yeah, well, no, it's not easy, and this is why when you were mentioning before how we actually get consensus. Well, the consensus, first of all, had to be made using evidence, scientific evidence, what we have in the literature, what we find out in different research, and actually is the base of any type of consensus. Then, of course, there is a second step that actually is how do you apply this consensus to your own practice and how do you apply this consensus to your own cultural aspect? And this is actually something that cannot be done with evidence because this actually is something that the physician, the surgeon, the physician in general had to apply when actually they discuss with the patient for the best possible treatment. In this aspect, the AI models, as has been mentioned, are great because help the surgeon. Nowadays, we have so many information. We have so many data that we need to put together. And of course, an algorithm, an AI system, if it's well developed, is able to do and to perform a little bit better than actually do it. I don't know better, but definitely quicker than actually I can do it. So this is actually an important tool. What currently is missing in every AI system that actually are available, for decision making, especially in medicine, is what we have been discussing today, the cultural aspect. That there is a very, we need to have, an AI system that is able to decide, which is better. When AI started, one of the typical element was the moral dilemma of an AI, the usual aspect of a car that actually is crossing the road and there is people crossing the street, and what is going to do the car, depending on what type of people that actually are sitting in the car or what the age of the person that is crossing the street. Each country was different, each region was different, because you give different value to the life. So in this aspect, the AI is not ready yet, but definitely is a great tool for us. But if you want to build up the consensus, the baseline is the scientific evidence, and then you need to work from them.
So we have been talking about collaboration, Professor Tang. So can you give us a concrete example of how collaboration has really made a difference?
Yeah, there's a lot of very successful. We were talking about collaboration nowadays. It's very important. We work together. We have these core principles we follow, but at the same time, we respect the difference. To give a clear, real-world example, I think is the global collaboration and to fight HIV, the AIDS. So this collaboration really has just transformed the HIV treatment and turned what was once a fatal disease into a manageable chronic condition. I think that is a wonderful example, and the entire world we worked together. So we all know in the early days, so the treatment is very valuable and is almost is not accessible for resource limited countries, and as a global community, and we worked together, and the researchers across the US, Europe, and later in Africa, Asia, we coordinated the clinical trial, we generated the data, and the World Organization, WHO, they managed to translate this scientific data into an applicable, practical way. And also they just have the resource, the fundings, and negotiate the drug prices, and implement the infrastructures to some resource limited regions. And this really has transformed the people's life, saved the millions people's life. I think that's a wonderful example. But in medicine, we should do more, and we respect difference, but we work together.
Well, my final question is for all of you. When we talk about an inclusive global healthcare system that's built on consensus, what's your understanding of inclusive here? What's your personal vision for the global health system? Professor Li, we can start with you.
Cooperation is very important. And as an example, we have a very close cooperation in our hospital. I work in the United Family Hospital now, and I organized the new department, just like Professor Wang, and he as a surgeon, and I as a endoscopist belong to the physician, but we have organized a new MDT department. We have a physician doctor and have a surgeon, have an oncologist, focus on the digestive disease, not the department only. So we also have a traditional Chinese medicine doctor. So it's a combination doctor. We focus on the disease development, not separate the patient that belong to surgery or physician or TCM. It's not this kind of work. So we focus on the patient. So maybe it's a patient-centered MDT department.
Yeah, Professor, well, how do you see international collaboration helping in the global health
collaboration system? Is very important for everywhere. It's very inclusive, not between the surgeons and the physician, endoscopist, and also the doctors and group, and the patient and his relatives. So just for example, if there's a small lesion in the stomach or in the colon, laparoscopists can't find it outside. The endoscopy can inside it to give a very clear margin and give a clear signal and this is quite meet the precision medicine. So we can laparoscopically resect it very safely and with a clear boundary of this kind of patient. So because of the techniques and the thinking of the medicine evolutions very nice, very rapidly, especially the AI era. So the cooperation getting more and more important.
Professor Tang, your thoughts on this?
Yes, I think it's international collaboration can really push healthcare forward and make it more inclusive and genuinely patient-centered, as we have discussed. I think that is very important. And one thing I think from my perspective, from my experience, is this collaboration, we cannot just focus on sharing data. And that collaboration has to beyond that's the data sharing and has to start with like a power, priority, and the perspective. And we need to include the different culture. So we have to just this collaboration has to be how to say it just include all the just different regions, different culture, different ethical group of people. So not only technology. I think that's something we tend to forget. We nowadays we talked about a lot of energy specific, just like AI, these things. I think in the same times we need to remember the development of the kind of social economy level globally is not very well balanced. I think in the same times as a medical profession, we needed to just keep this in mind and in order to have this make our international collaboration more effective, that can benefit to every single patient and not only in a certain region and the certain countries, and that it has to reflect a global diversity. Thank you.
And thank you. And Professor Volney, if we can get your final thoughts on this topic.
Well, look, the collaboration within medicine has never been really a big issue, even in the past, even actually it's a good thing of the medical community, regardless, the conflict, differences, issues, the medical collaboration has always been there because we, the medical doctors, the surgeon in general, they're well aware that actually the health of the global community is actually way ahead above any kind of differences that can be within the, the countries and the population. For me, the collaboration success, personally, my research field is actually a lot around, new technology, artificial intelligence, and new technology in surgery. So nowadays, China is really, really where technology in the medical field is developed. I travel to China 3 or 4 times a year, and it's always a pleasure for the purposes actually of getting information about new technology. So, the aspect of the collaboration is actually a key aspect for actually having to treat our patient better and to reduce the complication rate, to have to increase the life expectancy of our population. And I think on this aspect, the medical community has been better actually probably than our politicians in general, because we never stop even in time of conflict.
And certainly I've heard a lot of consensus amongst all of you here today. And certainly this has been a very insightful discussion. Thank you. And I think you made the great point that differences, they're really not just about contradictions or conflicts, right? They're opportunities for dialogue, for mutual understanding, and just for overall better decision making. So once again, I want to thank you all so much for sharing your time and your insights with us. We really appreciate it. And to our audience too, thank you so much for watching.